Now, it's been a minute. I've missed you all. There's been a couple of changes. One of them is I moved, and that took up a lot of my life. And also, this took a little bit of, reorganizing from my perspective. I also recently became the director for the Ultrasound Leadership Academy. Now, if you are unfamiliar with the Ultrasound Leadership Academy, it is a nonprofit whose mission is to spread ultrasound goodness in more of a this is exactly how you do it, with mentorship, with amazing education. And it's meant for those who did not learn it or don't have access to adequate ultrasound education. Now, we definitely are so happy to spread the love, spread the knowledge locally. But one of the things that we're very focused on is spreading it to those who maybe don't have access and don't have the means of accessing this. With the Ultrasound Leadership Academy, for every fellow that pays, that equates to a 1-to-1 donation for those that might not be able to otherwise access it. There's actually a scholarship application. We're very happy to have been able to give just a ton of access along with the one-on-one mentoring. And what that means is, the one-on-one mentoring is that we actually have meetings with you as frequently as 1 to maybe even 2 times a month, where we can kind of chat through stuff face to face via the internet, of course. And we review your ultrasound images, meaning that we have completely, myself included, qualified personnel that can kind of go through these images via a HIPAA compliant online sharing platform called Sono ClipShare that we actually developed on Core Ultrasound. We'll actually review and comment and be able to really help you grow as an individual. If you want to know more about it, make sure that you check out the ultrasoundleadershipacademy.com. You can send an email to the administration account, the inquiry account on the emails. You can email me directly as well to learn more. Without further ado, let's get right into this segment called the ULA, or Ultrasound Leadership Academy Image Review from Motion to Meaning, Episode 1. This is going to be a weekly or every other week installation, so look for it when it comes out. All right, our first case here that we have, and this is courtesy of Core Ultrasound, is we have this. Now, it's difficult sometimes to get fully oriented when you have an ultrasound clip without any specific kind of background. And to be honest, when I started doing ultrasound, I had a lot more patience for when we would get reports back from our radiology colleagues, from ultrasounds, from CTs and x-rays that said clinically correlate, because oftentimes it is difficult to know exactly what's going on without knowing a little bit about the patient. But that being said, oftentimes we can gather some general data, and that's what we're going to do here. Now, right here we have a bladder, and we have a uterus, we have the cervix down here, we have a vaginal stripe. This right here is bowel. You can see it kind of wiggling a little bit here with some air artifact and some dirty shadowing deep to it. Now, what we want to focus in on is the uterus itself. Now, this presumably was done to identify the presence or absence of an IUP. But when we look at this, I'm going to go ahead and pause it right here. When we look at this, we are seeing a very hyperechoic structure in the uterus right here with a little bit of a ring down artifact. This is what an IUD looks like. And we can see that it is in the center of that uterus. It is an adequately placed IUD. Now, we only got the one clip on here, just the sagittal view, which, to be honest, when I'm looking at the pelvis, that is most of the time, my preferred view. Often, if I want to look at the ovaries as well, I'll definitely make sure to get a really good transverse view as well. And it's always good to get, 2 views rather than 1 view. But this, if I get 1 view, I want this one. And if we had it in cross-section, we might be able to actually see the T of the IUD in there just to kind of confirm that it's right where it needs to be, right in the middle, right in that endometrial canal. But for this, without significant free fluid deep to it, I'm confident and comfortable saying that this is very likely an appropriately placed IUD without an intrauterine pregnancy. Now, I do want to comment on a little structure right here, this structure right here. Now, this is fluid, right? This is definitely fluid filled. And if you're not aware of this, you might be, I guess, a little bit concerned that this might be some free fluid in the pelvis, which definitely happens. But this is very likely some iliac blood vessels. Now, we can see here that there are some hyperechoic walls here and here. And we don't have color flow, but I bet if we put color flow on this, we'd be able to see color flow through here. And free fluid in the abdomen does not have color flow because it's not moving that fast. And so this, especially if we're not exactly center, or if we have the transducer just a little bit kind of tilted, is very likely an iliac blood vessel, even though it is not, confirmed with that color Doppler. So another finding that we can look at there. For our next clip or image that we're going to look at, this is no context. This is one that we received on our image review that we do through Sono ClipShare. And you can see here that we have a very likely liver. It's actually kind of difficult to tell if you have a structure here that is the liver or the spleen, but based off of the size, and I'll go into a little bit more, based off of the pathology, it is very likely to be the liver right here. We have a rib with some shadowing deep to it. That's why we can't see super well here. Another rib over here with some shadowing. And we have the spine down here. We can see it's kind of a little kind of bumpy. And that is the spine. And we're seeing a kidney over here. Now, looking at the liver itself, this, even though we're not getting a great view, there's a lot of motion. We are seeing what on this view appears to be normal liver parenchyma. Sometimes we can tell that a patient might have fatty liver if the echogenicity, meaning is it dark or is it more bright, of the liver, if it's much brighter than the kidney, then we would say it's more hyperechoic, which would be more likely to be a fatty liver. So that looks okay. Looking at the kidney right here, we're looking at the pelvis right here in the middle. And then surrounding it, we have the cortex. And in the cortex, I'm going to pause it. That's where the pyramids are, where they collect the urine. And then right here, you see how it's a little hyperechoic right there? This is normal, a bit of fat that's in the renal pelvis. It's supposed to be there. Now, when we're looking at kidney ultrasounds, we often are trying to figure out if there's hydronephrosis or not. That's one of the big things, at least in emergency medicine, that we're going to do kidney exams for. Although in other specialties, we might be also very interested in identifying the presence or absence of cysts or masses and being able to further quantify their likelihood of being cancerous based off of the Bosniak criteria, which you can Google. It's Bosniak. I don't see any hydronephrosis. Hydronephrosis would be a hypoechoic, so darker center that kind of flowers out into the periphery. We're not seeing that here. So kidney looks not bad. Liver itself looks not bad, but we definitely have some pathology here. And I'm going to pause it. Now, what I love about this is it really initially doesn't seem like the practitioner who did this scan saw it because of a couple of things. First off, it's very subtle. And the sweep for this specific indication, this is looking for free fluid in the abdomen, the sweep is a little bit too fast. We always, when we're looking for free fluid and we want to be the most sensitive we can be, we want to do slow sweeps. Because especially if the patient's breathing and we're in a bit of a panic, because let's say it's a patient with blunt abdominal trauma that is hemodynamically unstable, sometimes we get a little bit agitated and we want to do the exam as quick as we can, but we really have to be, just take an extra 1 to 2 seconds to do a slower sweep to be able to identify this very small bit of free fluid, this hypoechoic fluid right here in between the liver and the kidney. This is a positive right upper quadrant fast exam or focused assessment of sonography in trauma. right there. And you see, it's very subtle, right in Morrison's pouch, which traditionally is the location in which we are taught anyways to see free fluid, and we're definitely seeing it here. Now, I will say that this is not necessarily the most sensitive place to identify free fluid in the right upper quadrant, especially if the patient's laying supine when they arrive in your emergency department. Now, if they're supine, you want to definitely make sure to get over here in between the caudal tip of the liver and the inferior pole of the kidney. This is usually where free fluid will accumulate first, and then it'll kind of go up and down into that traditional Morrison's pouch view. So while we are seeing that small sliver of fluid here, and remember, the FAST exam is binary. It's either positive or it's negative. Of course, it's indeterminate also is a thing if you can't get a good view or you're not 100% sure. But once you see free fluid in any of the traditional or non-traditional windows for the FAST examination, it's positive. And to be honest, the way that the FAST exam, I believe, should be most efficiently applied is just, is there free fluid in the belly or not in a hemodynamically unstable patient? Because that tells you, can the patient go to a CT scanner, or do they need to be either sent directly to the operating room or transferred for presumed and highly suspected hemoperitoneum?
I first heard about ULA through when it was first advertised, actually at the time of one of the original Castle Fests, and was really intrigued by the idea of being a ULA member.
What about the ULA makes it a good fit for me? The number of instructors, the variety of experiences they have, the fact that it's moldable to what works for me in my practice as opposed to a set curriculum really makes it a wonderful learning environment, and it did.
The ULA and the leadership of Ultrasound Podcast has been really, really great to work with because they're very accessible and easy to talk to, and they're very helpful.
I think one of my favorite things about ULA is, in addition to being able to, almost instantaneously get information or questions answered, also the opportunity to talk to people who, not just, professors in my institution, but professors across the country who, have written the papers on this, been doing this for decades, and who really know their stuff.
It's very comprehensive, it's very focused, and it's 12 months long, and so it's not a weekend course where you sit down and learn a bunch of things sort of slammed in your head. You can go through each specific ultrasound topic very slowly and very methodically, so that the finished product is much more complete and comprehensive.
I think that the most profound thing from ULA, and the favorite thing, is actually personal. I feel like I've become a much better sonographer and a much better clinician as a result of the training. That was really my paramount goal of joining ULA. I feel like I got a great education, and I've really changed my practice style.
And probably most important overall for me is it's renewed an interest in emergency medicine in general for me, because I was kind of slogging through and getting a little bit burnt out. And then now, I'm revitalized, and every shift I can't wait to try to do as many ultrasounds as possible, and it's what makes it interesting to me again.
Here is another picture here where, and this is a different patient, but it's the next most common view. So the most common view for a FAST examination to be positive is actually the right upper quadrant when you look at the data. And the second most common is in the pelvis, and then the least most common is the left upper quadrant. Now, I'm going to spend a little bit of time just quickly just kind of going through that, because the most common structure that causes bleeding in a patient with blunt abdominal trauma with hemoperitoneum is actually splenic rupture. So you would think that the left upper quadrant is the most common, but just the way that blood moves in the peritoneum, it goes over to that right side more frequently. The other thing, and this is maybe kind of left over from my, med school experience, is I remember when I was in my surgery rotation, one of the questions I frequently got asked questions about is, what is the most dependent recess in the peritoneum when the patient is lying down supine? And that is the pouch of Douglas, or the rectovesicular or the rectouterine pouch, which is in the pelvis. So even though when you're looking at a picture of a supine patient, even though down there in the pelvis is the most dependent, remember blood, fluid, it's all going to creep down into wherever the most dependent portion is. Even though that's the case, the right upper quadrant is usually the first one to be positive, followed by the pelvis, followed by the left upper quadrant. And that's actually the order in which I do the FAST exam. Right upper, pelvis, left upper, because to me, if the right upper is positive, I don't necessarily need to move on to the rest because it's already positive, unless I have time or I'm curious, right? So I do that first, and then I move on to the pelvis if the right upper quadrant is negative. Now, we're going to look at this. This is a very quick sweep. Again, I totally understand that the practitioner who did this is very likely stressed out. There's probably a lot going on. There's 20 people in the trauma bay. They're getting IV access. They are intubating if the airway is an issue. They're trying to coordinate a bunch of stuff. And so I get the quick sweep. And this, unfortunately, was labeled as a positive pelvic FAST. Now, let's look at what this is. Right here, this is a sagittal view. So the patient's head's up here, feet down here. The back is over here, and the anterior abdominal wall is up here. This is the bladder. Right here, we have a prostate with a seminal vesicle. Now, this, on first glance, would be what a small bit of free fluid would look like, but we know that the peritoneum is actually above the bladder, right? There's a little bit of the dome of the bladder that is peritoneal, but the rest of the bladder is actually retroperitoneal. So, or extraperitoneal or retroperitoneal. It's not in the peritoneum. And so this right here is actually in the pelvis. So it's not considered the peritoneum, and the FAST exam is for peritoneal free fluid. This is prostate and seminal vesicle, not free fluid in the peritoneum, even though this is what free fluid would look like, a bit of hypo or darker hypoechoic fluid down here. And there is fluid in the seminal vesicles, right? Now, what we're going to do is we're going to look on the left side of the screen, which is actually cephalad towards the patient's head. And you can see here, this is the superior dome of the bladder. And deep to it, we're actually able to see deep into the retrovesicular pouch over here. And we're seeing stuff over here, which on this still, for me, it would be very suspicious for free fluid or blood in the pelvis. But as we kind of play through here, we can see a couple of things. Firstly, up here, you see how this is fixed. It doesn't really have shadowing going through it the way that we typically see with bowel. And we even see a bit of little hyperechoic kind of structures in there, but we're still able to see deep to them. Typically, if we have an air, let's say this is an air artifact, we wouldn't be able to see deep to it, but we're seeing a structure. Whereas if you look over here, this is air and we're seeing shadow deep to it. We're not able to see that up here. We're actually seeing a structure. This is actually clotted blood. So this is a patient that's had some blood in the pelvis long enough that it's actually clotted. Now I'm looking down here in the pelvis, and this right here also looks like a bit of blood. This structure here is very likely one of the iliac blood vessels. But looking at this right here is fresh blood, and we're off to the side a bit. This is fresh blood, and we know it's fresh blood because it's very uniformly hypoechoic, and the way that we know very frequently that fluid in any place is physiologic fluid or not, and I mean fluid in the peritoneum versus like fluid in the gallbladder, let's say, is that usually if you have fluid in a structure that it's supposed to be in, it's encapsulated. It's in a bit of a kind of circle. It's in a sac, right? Now, if you see this, you see how there's a bunch of jagged edges here. When you see hypoechoic something with jagged edges, what you're seeing is you're seeing fluid in between the mesentery, in between the intestines. You're seeing it just kind of be where there happens to be space for it to be. And this is why knowing that you have to do these slower sweeps and know what clot looks like is so important, because if not, you might miss a significant amount of hemoperitoneum like we see here. Next up, we also have some fluid not where it's supposed to be. Now, this is a bit of a zoomed in view. We have the liver right here. Honestly, it could be the spleen. It's the liver or the spleen. It's one of those right upper quadrant, left upper quadrant structures. Doesn't really matter. What we're focusing on, though, is this right here, the kidney. Now, we spoke about it in the first video where we discussed the right upper quadrant examination, where we're looking for hydronephrosis, often in the kidney itself. And I do see a little bit of hypoechoic stuff within the pelvis. I'll be honest, I'm not 100% sure if this is just renal vessels or a little bit of hydro. The way that we tell the difference is we put color flow on there, and if we see flow go through that hypoechoic thing, then we'll know it's a renal vessel. Even that being said, even if it is hydronephrosis, it wouldn't be bad hydronephrosis. It'd be mild hydronephrosis. And I'm pausing it right here, and I'm seeing a little bit more over here. This also same thing. Could be a little bit of hydro, could be prominent renal vessels. Color flow would really help us out. The pathology that I'm looking at here is actually a bit of, I don't know exactly what it is, but a bit of some kind of fluid inside the capsule of the kidney. And this is what we're seeing right here. Now, this is not abdominal free fluid. This is not outside of the capsule right here. This is the capsule, or I think it's Gerota's fascia. I'm trying to go all the way back to med school. There's a little bit of fluid inside Gerota's capsule, Gerota's fascia. And this means that this fluid that is in a place where it's not supposed to be is coming from the kidney itself and is staying within the capsule. And that could be a couple of things. That could be due to trauma. Sometimes we see this in the setting of an abscess/infection. And the most common, at least in my practice, is to see something that has a couple of names. The more fancy name is pilosinus extravasation, but I like to just use the more simple term, and that is calyceal rupture. When you have hydronephrosis, sometimes the hydronephrosis causes so much back pressure, so much back pressure that the distended calyces actually will rupture on the inside and spill some urine on the inside of that kidney capsule, at Gerota's fascia or capsule, causing that little bit of free fluid that we see here. And clinically, let's say this was due to an obstruction such as a kidney stone, sometimes what will happen is it will be a picture kind of similar to when you have a ruptured appendix, meaning they have a significant amount of pain. Something happens that is not like you didn't give them medicine. Just something happens and their pain kind of goes down a bit on its own. It's because the distension has relieved a bit. So that kind of stress on the capsule, on the kidney, relieves enough that the pain goes down a little bit. So clinically what will happen, if this is a calyceal rupture in the setting of obstruction, is you'll have a patient with a lot of flank pain, and then they'll have, without you doing anything, they'll get a little bit better. This is what you might see with ultrasound. And lastly, our last one that we're going to talk about on our episode 1 of our ULA image review is a very common false positive that I get, especially with the left upper quadrant view. So let's talk about this. So we have the spleen right here. This is definitely the spleen. And we have a bit of the kidney here. Now remember, the spleen, or the left upper quadrant, said it a little bit more accurately. The left upper quadrant is not a mirror image of the right upper quadrant. The fluid actually will accumulate, in the setting of trauma, a fast examination, but really any peritoneal free fluid will accumulate preferentially maybe in a different area. So we talked about how the right upper quadrant, it's usually going to be in the inferior pole of the kidney, caudal tip of the liver interface, and then creep up into Morrison's pouch. And then the least common is actually for it to just be isolated in the suprahepatic region, just underneath the diaphragm. In the left upper quadrant, however, it actually is basically the opposite. The most common place is actually suprasplenic, followed by the paracolic gutter or the inferior pole of the kidney and the caudal tip of the spleen, and in between the spleno-renal interface. As far as I know, it doesn't have like a fancy name like Morson's pouch. So if we look at this by itself, this is actually suprasplenic. Remember, this is the patient's head, this is the patient's feet. We have the probe marker on the side with the probe marker facing up, on the left side, probe marker facing up. And we are seeing definitely some fluid here. But here's the thing, is as we kind of fan through, you see how it's a bit encapsulated, right? And also there's these little hyperechoic things in here. This is actually a stomach that is full of something, right? Could be food, could be water, could be Cheetos, who knows? I don't really think of Cheetos as real food, so that's why I put that separate. But this is the stomach that we're actually seeing right here. This is normal appearance of stomach. And this, the way that this looks, with a bit of an encapsulated type structure with some irregular kind of ridges. These are actually rugae in the stomach. You might see something similar, but a lot smaller in a small bowel or even in the large bowel. Something that's a similar type picture. Now this right here is usually because the beam, right? Let's say the beam is here, and this is much higher up than my abdomen, but the beam right here, we have it a little too anterior, because if we see the stomach, it means that our probe is actually a little anterior because the stomach is more anterior. And if we want to get a view where we don't see the stomach, we need to just angle the probe a little more towards the back, which is where the kidney is. We can see here, right here, we angled it a little more posteriorly, and you see now the stomach is a lot less prominent, and we get a great view of that spleno-renal interface right here. And if we're able to bring the transducer a little bit farther down, we'd actually get the paracolic gutter as well. So the closest view we get here to like an adequate view to look for free fluid in the left upper quadrant is just a little, like one frame basically. Let's try to find it right about here. It's probably the best view that we can kind of obtain looking at the left upper quadrant for free fluid. And it's kind of an obscure view. Honestly, I can't really tell. This right here could be free fluid, but I think more than likely it's actually a muscle based off of this right here, because this is a muscle. And then based off the fact that the peritoneal lining is very likely this thing right here. But it's really hard to tell in this view. So with this view, I would actually call it, if I saw this, I would actually call this one indeterminate, because I don't really have a good view of the place I need to look for, which is the superior portion of the spleen or the suprasplenic area. Although it does look a little weird, like there's something over here that I really don't understand what that is. It could be a mirror artifact. It could be actual fluid either in the thorax or in the suprasplenic region. This is a common false positive. So know that if you see something that is kind of encapsulated, but not in a perfect circle or perfect oval, there are edges around it, and you see these hyperechoic little things in there that they will move around if you keep it steady, that is the stomach. If you see that, rotate or fan the transducer to angle the beam a little more towards the back to get that perfect left upper quadrant view. Now, if you need a review, we definitely have very in-depth videos on the Ultrasound Leadership Academy video platform, where we have a 12-month curriculum of a bunch of video lectures that I actually put together myself. And I actually love this curriculum because it is as nerdy as I get to be, as I want to be. I really walk you through all of the little nuances, including the data behind it and appropriate use and all this stuff. It is accessible, and we have a bunch of different packages as well. If you just want the videos, you can have that. If you just want image review, we have that. If you want to go all the way up till I am basically mentoring you through a full year of really powering up your ultrasound practice, go to the website, check it out, and can't wait to hear from you.